Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about cirrhosis of the liver. Cirrhosis of the liver is a very common medical problem. Worldwide, there are 500 million folks who suffer from cirrhosis of the liver. In this country, 5.5 million folks suffer from cirrhosis of the liver. And every year, 25,000 people in this country die because of cirrhosis of the liver. And of course, worldwide, several hundred people died every year because of cirrhosis of the liver. I went over all the reasons why people develop cirrhosis of the liver, namely hepatitis, alcoholism, obesity, etc., etc. Now, I was in the middle of discussing the complications when I left off last week, and I was at the point where I was talking about bleeding, which is really one of the major complications of cirrhosis of the liver, and I explained how the bleedings, what's the cause of the bleeding. And when I was describing here the bleeding that occurs in the esophagus, I mentioned two problems that develop. Number one, of course, is esophageal varices, which is right here and at this junction here because of the portal pressure that develops in the spleen. The liver is occluded with multiple little vessels and medium-sized vessels that are destroyed pretty much because of the chronic inflammatory process that's taking place inside the liver, leading to the body needing to create new vessels. And the new vessels, of course, are created right here at this juncture. We call them esophageal varices, and they bleed spontaneously, profusely, leading to major bleeding inside the stomach, leading to blood being passed to the rectum, etc. And here, the problem here is not gastritis. Over here is esophagitis. Esophagitis is when there's an inflammation that occurs. There's an inflammatory process there with swelling, redness, and all this stuff. That's called esophagitis, not gastritis. Gastritis is here in the stomach when the same processes are taking place inside the stomach, namely the swelling, the inflammation, the redness, all the superficiality that occurs here in the wall of the stomach. That's called gastritis. These things lead to bleeding as well. Okay, so if I mistook or misspoke by saying gastritis, it is in fact esophagitis. Okay, now, one of the really bad types of bleeding that can develop is something we call disseminated intravascular coagulopathy, named DIC. Now, it is very difficult to diagnose DIC in the setting of a liver that's failing when the partial thromboprostate time is already elevated because the level is low and the liver cannot produce it. The prothrombin time is elevated. The RNR is elevated, again, because the liver cannot produce this product. So you have the abnormality here. The usual way one goes about diagnosing DIC will not be of very much help because you have so much inflammation going on, and one will do, let's say you will do fibrinogen. Well, fibrinogen is a phase 2 reacting protein. So in the middle of the liver failing with all the inflammatory process that's going on, the fibrinogen level is going to be falsely elevated. So that's going to confuse the picture. However, I will give you a little pearl to put in your back pocket. You would have to make it your business if you really want to know, which you need to know because, and I'll tell you why you need to know whether the bleeding is the result of DIC or the abnormal coagulations are made worse because of DIC or not, because of the way one has to approach these things. The best thing to do, since these are not going to help you, you're going to have to take it your business, the physician, to go to the laboratory, the hematology laboratory, either ask the technician or as a hematologist, get a hematologist involved. Almost always in this setting, we have so much bleeding going on, you definitely should have a hematologist involved in the care of this patient, someone who understands coagulation inside out that can help you to, number one, diagnose the problem, and number two, how to handle it the best way. And of course, the key test here is something really very simple. You will take a drop of blood from the anticoagulated blood from the lavender tube, make a blood smear, and you would put some alcohol on it and then dry it in the appropriate manner, and then stain it with Gram Jimza stain, dry it out, put some oil on it, put it under the microscope. Well, what would you be looking for under the microscope? You're looking for red cell fragmentation. That's right. Because when you have DIC, you will have schistocyte. Schistocytes are when the red cells have been eaten away, being eaten away a little bit at a time from the edges, and you have partial leftover red cell we call schistocyte. That is the only way in this setting, the best way you could diagnose DIC. It's simple, it's not expensive, it doesn't require any fancy machinery, but just go into the laboratory, get the hematologist involved. The hematologist, he or she, knows exactly what I'm talking about. They will look at the blood smear, putting all this stuff together. Then when you have, because when you have elevated prothrombin time, elevated thromboplastin time, you have all these things that are abnormal, low factor VIII, etc. It should have nothing to do with you having fragmented red blood cell. And if you have, in this particular setting, a liver that's failing because of the cirrhosis, massive bleeding all over the place, and you want to know, is DIC playing a role in it or not, then you go to the hematologist. He or she will go to the laboratory, look at the blood smear, and look for schistocyte. Something that simple. Okay. Now, what could possibly be the reason why somebody will be developing DIC in a setting of massive bleeding because of cirrhosis of the liver? Well, when one is bleeding profusely, one is likely to drop one's blood pressure. And the hypertensive state itself, the hypertensive, or the most common cause of DIC is hypotension. Either it's due to sepsis, or it's due to bleeding, or some other cause of massive volume loss of one kind or another. The hypertensive state causes certain reaction to take place inside the blood vessels, resulting in releasing from the wall of this blood vessel something we call procoagulant proteins. These procoagulant protein interact in a way that leads to this reaction we call intravascular coagulopathy. Disseminated mean all over the place, disseminated intravascular coagulopathy known as DIC. That's how DIC develops. And that's how it would happen here in this setting. Of course, as you well know, the liver is very important in the maintenance of the immune system. So when the liver is very sick, that individual who's suffering from it, he or she, is more prone to develop infection. And such as the infection then can lead to sepsis, which can frequently occur, resulting in DIC as well. So it's very complex. It's a multifactorial issue. The important thing that has to be known is that in this setting, even though I have not yet begun to talk about treatments, which I will, either in this segment or another segment, is when you have DIC, which is a terrible syndrome that occurs in medicine, usually the sicker the patient, and you wind up with having to deal with DIC, which makes matters worse, is to treat the underlying disease. That's it. That's the mechanism, to treat the underlying disease. But you can't treat the underlying disease because the liver is so sick. Your only resort would be to do a liver transplant, which I'll be getting into when I start talking about treatment. This is it. Otherwise, you just sit there and try to maintain the patient best you can until the situation eases itself. Because when these things are happening, it's multifactorial. There are multiple organs involved. And as you take care of one thing, something else happens, and you just hope and pray that the stuff will get better. Now, you say, well, you have DIC, the platelet count is low, the red blood cell count is low, the coagulation profiles are abnormal. Why don't you replace those things? Well, you really cannot. The only thing you could replace in this setting is a red blood cell, because you can't give patient platelet when they're having DIC. They're destroying the platelet. You can't. It's just like taking gasoline and pour it on top of fire. Can't do it. It's going to make the DIC worse. Okay? So you can't do that. You can't give them platelet. The same thing happens. You can't treat them with fresh frozen plasma to replace, to try to correct the elevated protoning time, elevated partial thromboplastin time, etc. Can't do that either. The same thing. It's just like taking gasoline and pour it in the middle of a fire. It's going to make it worse. Okay, so you can't do any of that. What you can do, however, you could transfuse the patient with red blood cell, try to maintain the patient's blood pressure so as to enable the patient to perfuse the brain, perfuse the kidney, perfuse other organs that are necessary to be perfused to maintain life. That you can do. Okay? That's about all you can do in this setting. But it is very important, however, to know whether one has DIC or not. Because if you don't have DIC, the blood smear does not show schistocyte, because that's all that can help you. I don't care how many millions your machines cost. You're wasting your money. The easiest way is to look at the blood smear in this setting. You don't have to spend a lot of money doing a whole bunch of other tests to make the chart look good, etc. It ain't going to happen. It's not going to help you. What can help you, look at the blood smear, you see schistocyte, you just diagnosed DIC, and then you know how to approach the treatment for this bleeding that's taking place. A whole host of other stuff has to be taking place. First of all, you have to have a gastroenterologist involved in the management of this patient. You can't have very bad liver disease and don't have a gastroenterologist involved in the management of this patient, in particular individual doctors who specialize in liver itself. We call them hepatologists. Okay, so that's just because I'm describing all these things to you as a teacher of clinical medicine doesn't mean that I always sit down and do them myself. I can do them, but that's not the way medicine is practiced. Just because I know how to do these things does not necessarily mean that I'm going to be the one doing them, nor should a general internist do these things. Because you have specialists out there that are eager and able to help you. Because when you have somebody bleeding here from esophageal varices, you need the help of a gastroenterologist to scope the patient by putting the endoscope, go down there and try to see if he or she can cauterize these things to try to stop it, temporize it, if anything else. And there are, again, balloons that have been used. I don't know these days what's going on. I'm not on the floor taking care of these folks like I used to when I was in training any longer. I'm sure there are better techniques right now that they can use to try to put pressure on these things to try to stop the bleeding. I mean, when I was in training, I know it was disastrous to try to do these things. There are other ways, again, these things are done. When I get to talk about treatment, I will be able to talk to you about the different medications that are out there to try to lower the portal pressure as a way of helping the situation. Okay, again, I'm not on the floor anymore doing these things. When I was teaching and training, we used to have to do this stuff when I was in training as well. Again, I'm sure there are better techniques on how to do these things now, but that's the basic concept. So bleeding then is the major problem. And of course, with all the things that's going on with the bleeding, with the patient going into shock and can lead to strokes and kidney failure because of this shock state, etc. Because, you know, if you don't have normal blood pressure and you're bleeding, you can't perfuse the kidney, so the kidney function tests are going to become, the kidney is going to become abnormal, making the whole situation even worse. Even worse, okay? So, but of all that I'm just discussing with you, one of the worst part of all these things, if you can imagine something getting worse, is when the liver is in fact is failing. And the liver is failing with all these multitudes of things taking place. And part of the reason is because the liver cannot handle protein because it's too sick. Ordinarily, anyway, the protein has to go down to the large bowel here to be broken down. And the bacteria, there are billions of bacteria in the large bowel that work on the protein that we eat to finalize the breaking down of it. Inside the large bowel is located the ammonia cycle. This is where the ammonia begins to be produced. Right here, this is where the ammonia is produced. And it gets taken back to the liver to be processed further so that amino acid and the extra stuff can be made. Very important, but the liver cannot do that. So once the ammonia gets down here, and it's once the protein gets inside the bowel, it's inevitable ammonia is going to be produced. That's the process. That's how God created the body. That's one of the reasons why the bacteria are there for. People don't think that the large bowel is just an organ that sits there just as a receptacle for stool. It does that too, but it also has major health benefit to the human body. It's a very important organ, not just to hold stool for us to evacuate. Now, we do that as well, but there's a whole lot of good health processes that we need colon for. So once the ammonia is produced, it gets to the liver can't handle it, and then the whole situation is really going completely out of whack. Because now what's happening, ammonia is extremely toxic, very toxic, and the patient can in fact slowly beginning to get very sleepy, extremely tired, start falling asleep, and then through falling asleep to going into full-blown coma, something we call hepatic encephalopathy. This is it. This is the worst of the worst. That's the worst step that we fear the most, is when someone goes into hepatic encephalopathy. Okay, that means that the liver is failing. The liver cannot handle the toxic material that's piling up in it, because all the stuff that we inhale, or a lot of the stuff that we drink, a lot of the stuff that we eat, has to be processed by the liver ultimately. And the toxic stuff, the liver is the big detoxifier. The liver and the kidney and the lungs, and the lung we exhale bad stuff that we inhale, we exhale them. Hopefully they don't do severe damage to our lung, but we exhale them to get rid of them the best we can. The liver everything goes to the liver to be detoxified. That is why alcohol is so toxic when it is consumed in large quantity, because the liver cannot handle. The liver tissue was not created by God to be handled something as toxic as alcohol in large quantity. So the liver tissue gets damaged. The alcohol itself causes the inflammation. That's right. Alcohol itself causes the inflammatory process to start. And once the inflammatory process begins, it eventually gets worse and worse as the individual continues to consume alcohol on top of what's already there. And then the inflammation ultimately becomes chronic. The chronicity of the inflammation is what caused the scarring to occur in the liver. And it does not necessarily have to be alcohol. Anything that is damaging to the liver that doesn't belong to the body goes through the same process that I just explained, then ultimately wind up with the scarring, resulting in cirrhosis of the liver. Okay, and when one does a physical examination, in the beginning of liver cirrhosis, the liver is enlarged, the spleen is somewhat enlarged. As the scarring gets worse and worse, the liver gets smaller and smaller, the spleen get larger and larger. And the reason why the spleen get larger because the portal pressure increases. As the portal pressure increases, the spleen get larger and larger, and the liver gets smaller and smaller. Okay, so this is incredibly important, difficult stuff, physiology stuff that has to be discussed. So the bottom line is one cannot survive without a good liver. Okay, so now that you have an idea what is going on inside the liver, what can cause all this problem, I'm going to begin to talk a bit about treatment. Treatment of liver disease, in particular cirrhosis of the liver, is very, very, very important and very tricky. So one has liver disease. It has been diagnosed by the first by the history, followed by the physical examination, which includes everything from the skin, because if the liver is very sick, there'll be jaundice, there'll be a whole host of other abnormalities that can be found on the skin, from spider angiomata, from a whole host of other abnormalities that one can see on the skin. The quality of the hair, the eyebrow, etc. These things are important because the sicker the liver, the less it is able to handle certain hormone that we ourselves produce, and the liver cannot break it down, resulting from a whole host of other problems, both in women and men, because of the excess hormone that's sitting there. There's a hormone, as I mentioned in previous shows, called aldosterone that is produced by the kidney. The excess aldosterone sits there, it cannot be broken down. So you wind up with salt retention because aldosterone leads to the production of sodium, excess sodium production. Wherever sodium goes, water is going to follow. So you wind up with swelling in the abdomen, something we call ascites, because of the excess, because of secondary hyperaldosteronism, leading to swelling of the leg. Third spacing meaning that the body is compartmentalized into different compartments, and we have a system we call that allows the oncotic pressure. There's an invisible pressure we call the oncotic pressure that prevent things from moving from one compartment to another. Well, to have a normal oncotic pressure, you have to have a normal functioning liver that produces enough albumin to allow that to happen. Well, when the liver is very sick, the serum albumin is low. Because the serum albumin is low, the oncotic pressure is low accordingly, resulting in fluid seeping from the intravascular system into the extravascular system we also call third space. So water is moving freely. That's how the belly gets all swollen, the thigh, everything, the face gets all swollen, that third spacing. And there's a whole concept on how to treat that swelling. You can't just say, well, here's some Lasix and take it. That's not how that works. I'm not going to sit here and detail all that to you. The chapter 59 in this book, The Best of Clinical Medicine for the 21st Century, that I wrote last year, you could find that probably in your local public library. Chapter 59 details some of these things for you, how one goes about increasing the oncotic pressure in conjunction to giving the person the loop diuretics such as Lasix, etc., to try to get the fluid to move back to the... See, the fluid is going to stay on the third space. You can't move it from the third space out of the body. For the fluid to get out of the body, you have to move it back into the intravascular system. That's it. You got to know how to do that. You got to know how to... And you can dialyze the patient all you want. That ain't going to do it. So you have to know how to get what to do to get the fluid back to the third space. Back to the intravascular system from the third space, so that then your Lasix and your whatever other loop diuretic you choose to use is going to get the person to urinate that. But to do that, you need a normal kidney. You may not have a normal kidney. That's the problem. Because of the liver that is so sick, you may wind up with significant kidney disease whereby the kidney itself is not able to get rid of that. This is complicated stuff that I'm telling you, but that's the way you got to go about it, okay? So you carry your physical examination, you do all that stuff, then you're going to get your abdominal ultrasound to try to take a look at the liver, get a CAT scan to take a look at the anatomy of the liver. You get all that stuff done. Then having done that, you try the best you can before things get worse, before the coagulation tests get worse, to get yourself a liver biopsy. Because the worse the coagulation test, the lower the platelet, the much more difficult it is to get a liver biopsy because the patient might bleed. So you try to get that ahead of time, and most likely these days it's probably smarter to get the interventional radiologist to do the biopsy for you, because they use tiny little needle. They can visualize the liver under the CAT scan. While they're looking at the CAT scan, they go under the thick piece. That's all you need, is a tiny piece. But if you go there with a big needle to try to zap the patient liver, you might wind up with a catastrophic bleed. You don't want that, okay? I'm sure liver biopsy is being done all over the place, and those guys are great at what they do, but I'm telling you, one has to be very, very, very careful, okay? So you get your biopsy done. The biopsy will show you what is happening pathologically to this liver. And then you have an idea how advanced the cirrhotic situation is or is not. And that helps you in the management of the patient as well. Listen, I'm going to stop here. Next week, I'm going to continue to talk about treatment of cirrhosis of the liver. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.